Everyone. This is Dr. Sam George, one of the anesthetic IT consultant at Georgia Leyden and Eton, UK. And I've often been asked to, talk about AKI, acute kidney injury. And what I find is uh, speaking about AKI is quite incomplete without speaking about circulatory shock, because they form the major components of shock itself forms a major component of um, factor leading to AKI, and therefore understanding the principles of managing circulatory shock is very important. The physiological principles of managing circulatory shock. So I have a personal generic approach to management of circulatory shock, which I believe could um, help with a lot of scenarios to prevent your patients from going into organ failure, to resuscitate somebody who's just come out of a cardiac arrest, and to uh, to rescue somebody who's gone into AKI. So, and circulatory shock could manifest in so many ways. It could be hypovolemic, distributive, um, obstructive, cardiogenic. In all these scenarios, if you stick to this principle, you'll never go wrong. And I can show you at various occasions that it's the same principle that has to be applied. So let's look at it. How would I approach? I'll just take you through how I would approach a case of somebody who's hypotensive coming to A&E, and what are the principles or rationales behind it. So when I approach a patient, obviously ABCD has to be done as ALS is suggested, but at the same time, has to be ingrained within that. That's what I believe could make the difference, because these are the things that you're bound to do in a patient. So first step is optimize the oxygen content. Look, it's all about oxygen being delivered to the tissues and the organs to prevent failure of these organs. Circulatory shock is all about hypoperfusion due to lack of oxygen delivery, leading to lack of oxygen delivery, and accumulation of metabolites like lactate. And so the principles are optimizing oxygen content, improving cardiac output and blood pressure, and improve organ blood flow. Okay? So how do you improve the oxygen content? How is oxygen delivered? Essentially, oxygen is taken by the hemoglobin forward. So oxygen is carried by hemoglobin, and there's a dissolved fraction in the plasma. And that's what we mean by optimizing oxygen content. So if I approach a patient, I'll quickly look at what is the saturation, what is the blood gas, what is the blood gas arterial saturation, and what is the hemoglobin on that. A quick look at that. And that'll often tell me, is there a problem with the oxygen content? And dissolve, the oxygen in solution mentioned here is a very small fraction. So I would not, in practical terms, I'll not hang on to that. But that's the dissolved fraction of oxygen plasma. It's indicated by the period. Now, the next step I would do is I will just go quickly to the patient, and my concern will be looking at the cardiac output and the blood pressure. And I'll try to improve both. How do I improve the blood pressure? First of all, knowing that it's a product of cardiac output and peripheral resistance. And cardiac output is a product of stroke volume and heart rate. And my focus will straight be on heart rate, because any brady or tachyarrhythmia can be dangerous and life-threatening. But we'll just apply the ALS protocol, ACLS protocols. What's important is the generic principles are quite simple there. The generic approach in managing tachy or bradyarrhythmias, you go for electricity or pharmacological interventions. So I just try to simplify it for you, so it's easy to retain and there's no confusion there. Okay, and then we look at stroke volume. The components of stroke volume are preload, contractility, and afterload. And how would I know if the preload is there or not? Obviously, you give a you look at the response to a fluid bolus. That's what I would do. I would run a quick bolus of 20 to 30 ml per kilogram. Like if I get a septic patient, that's what I would do. Sometimes the requirement could go up to 4 to 6 liters of fluids these patients may require. If the blood pressure improves, it could be suggestive of a decreased preload. If improves, it could be suggestive of a volume, they're responsive. It could be suggestive of decreased preload and a reasonable contractility. But if there's no improvement or a worsening blood pressure, it could be suggestive of a larger preload deficit, contractility problem, or it could also be suggestive of an afterload problem. So do not miss these patients and do not keep giving them fluids. So you always have to think about the next step. You can't do much if the patient is not fluid responsive in the ward. So you have to think about escalating care to intensive care or CCU at the earliest. Okay. Now, contractility. How would I estimate contractility? Again, do a quick examination. Sometimes, if you're good at examination, you can find S1, S3. You know the patient is in failure. You can hear gallop rhythms or other factors. But if there's any history suggestive of ischemic heart disease or CCF, do not miss it, and try to elicit the functional or the exercise tolerance for this patient. Check echo ECG results if available. A high systolic pressure. If I see a high systolic pressure, usually I'm happy because that's indicative of a good contractility. Okay, and the question at this point is, if they are not fluid responsive, you have to think, oh, could this patient benefit from inotropes, especially if they got poor underlying heart. So again, it's you have to think about escalating care. And then comes afterload. Check if the echocardiogram is suggestive of any obstructive features. Afterload is increased by increased systemic vascular resistance, aortic pressures, high aortic pressure, ventricular dilatation, and aortic stenosis. So if there's any scope for surgical or medical intervention, you have to think about that as well. An increased afterload, the consequence is there's a decreased stroke volume and there's increased end systolic volume. Okay, now let's look at, I would always look at the peripheral resistance. Okay, quickly after going through all these you go through simultaneously. Basically, they're not discrete, different compartments, but you have to systematically. You should have checked all these factors. So peripheral resistance. Now, a good analogy for it is if you think of your garden hose. If the garden hose gets dilated, it's very elastic and loose and lax. Obviously, fluid will not reach from one end to the other. You need a reasonable amount of squeeze on your garden hose, a reasonable amount of resistance so that the fluid flows from one end to the other end. So if peripheries are cold, could indicate increased vascular resistance. If peripheries are warm, could indicate vasodilatation and decrease vascular resistance. A low diastolic blood pressure could indicate a low vascular resistance. A high diastolic blood pressure could indicate increased vascular resistance. And obviously, check if, next question is, will this patient benefit from vasoconstrictors? Again, if that's the case, escalate care to ITU. Okay. And example of low diastolic blood pressure, early sepsis, you can see there's low diastolic blood pressure. Even severe sepsis, you can see low diastolic blood pressure. If peripheries are warm, yes, septic patients, peripheries could be warm. And hypercapnic patients, peripheries could be warm because they're vasodilated. Okay. Cold peripheries, sometimes it's a fag end of, like in cardiogenic shock, you can see, because there's no perfusion. Or the peripheral resistance is very high, you can sometimes feel in that as well. And next, now improving blood pressure, you've done that. You've improved the cardiac output, you've improved the blood pressure, and improving the blood pressure improves the mean arterial pressure, which is the driving pressure. It can also be calculated as the diastolic plus 1/3 of pulse pressure. Now, next step is improving the organ blood flow. So you've got to know the formula for organ blood flow, and which is, first you essentially improve the perfusion pressure by improving the mean arterial pressure. And the formula for perfusion pressure is equal to MAP minus CVP, or the compartment pressure, whichever is higher. So that's the formula for perfusion pressure of an organ, P1 minus P2, It's equivalent to mean arterial pressure minus central venous pressure or compartment pressure, whichever is higher. So if a patient has raised intracranial pressures more than the central venous pressure, that becomes the opposing pressure, and therefore you have to consider that. And in order to improve the perfusion under those circumstances, we may increase the mean arterial pressure so that the perfusion pressure is maintained. Right, okay. Next is how do you improve the organ blood flow? The formula for organ blood flow is P1 minus P2, which is the perfusion pressure as mentioned above, and divided by organ vascular resistance. So, which means the more the resistance, less the flow. So, imagine again, if the organ vascular resistance, the brain edema, is significant enough, it will oppose the blood flow. So, organ vascular resistance is quite important, and it helps decrease the blood flow. Now, coming back to this perfusion pressure, imagine it's the kidney and the abdominal compartment pressure has gone up. So you'll have to consider the abdominal compartment pressure instead of the CVP if you're talking about renal perfusion pressure. Okay? And third is you think about trying to match the renal autoregulation range. The knowledge about autoregulation really helps. Autoregulation of blood flow essentially means the blood flow is maintained irrespective of the blood pressure within a particular range for these organs. And they tend to autoregulate and maintain their blood flow irrespective of the blood pressure, but within this range. Okay? And these can get affected under injury or insult or inflammation. Okay? But it's around 70 to 170 millimeter mercury mean arterial pressure for the kidneys. For the brain, as you can see, 65 to 130. Heart is 50 to 150. And if they're hypertensive, the autoregulation values could shift to the right, which means the autoregulation ranges could increase. Can you see the kidneys are quite sensitive? They are basically filters. They sit in the arterial system or the vascular system, and they help filter out, and they require a higher perfusion pressure. And therefore, if you monitor the kidney function, basic monitoring like urine output often helps understand that they're being reasonably perfused, which means the other organs are definitely being perfused because their requirements are low, as you can see. Right, and if they're hypertensive, they may require a higher perfusion pressure, and they may require higher mean arterial pressure to drive and perfuse their organs. So, if the patient that I was talking about, if I'm managing the case, I usually target a mean arterial pressure of 65 plus, and if they are hypertensive, they're old, I usually target around 70 millimeter mean arterial pressure. And if they are real hypertensive patients, I may target 75 millimeter mean arterial pressure. And what do you titrate it against? What do you target against? Obviously, you look at the the urine output. You look at the base deficit. How it changes. So essentially, looking at the functions of the organ, you can look at their conscious state. Does it improve? You can look at if the ischemic changes on the ECs have gone back. Are they generating a good blood pressure and things like that? Okay, so that's how we would manage. And that is the generic approach to management of circulatory shock. I hope I've made it clear. Thank you guys for listening.